This is a little bit different because in our abdomen, there's a lot of things going on. Unfortunately, we can't see most of it or any of it. And sometimes in our abdominal emergencies, things can be going on that are a little bit tricky. Most of the absolute diagnostics in this area have to be done at a hospital where they can do x-ray, CT scans, lab tests, things like that. So this is kind of a gray area for EMS. So I'm going to teach you just some rules of thumb and some things to look for, and going to help you make a better not a diagnosis, but better treatment decisions for your patients. So let's talk really quick about the anatomy and physiology of the abdomen. Okay? There's lots of organs in there, and they all play a part in several different body systems. We'll talk about those systems in just a minute. But because of this, it's a little bit confusing to determine what is the cause of our pain and how to best treat it. So your assessment is going to be key in this. If we do a very thorough assessment, and this really isn't something we can just wash over, it's a little bit of a physical assessment, but there's a whole lot in the history taking and the conversation that you're going to have with your patient that's going to give you some clues about this to help you treat, and also to pass on to the hospital staff so they can make better treatment decisions themselves. So our abdomen is our region between our diaphragm, which is the top part of our abdomen just under the chest, between the diaphragm and the pelvis being the bottom floor of our abdominal cavity. So in that, we're going to find organs that are part of the digestive system. We're going to find organs that are part of the reproductive system, both male and female. There's going to be organs in there that play a part of the endocrine system. An endocrine system is a system that, for the most part, regulates our hormones. So it plays a huge part in how the rest of our body functions. And then the regulatory system to keep homeostasis, keep our body regular. So here's the abdomen and the organs that are found there. And you can see over here are our solid organs. And those solid organs consist of the spleen and the liver, which both filter blood, the pancreas, which a big function of the pancreas is to produce insulin so that our body can utilize the sugar that we consume. And then the last solid organ are the kidneys. Now, solid organs are very vascular. There's a lot of blood through them for the most part. And so if they become torn or fractured or damaged or ruptured, we have significant bleeding issues with them. Now, if you look over on the other side of the screen, here's a small diagram of the hollow organs that are in the abdomen. Stomach, in the gallbladder, which is very small and sits over on the upper right-hand side of the abdomen. The duodenum, which is part of the intestines. We have the large intestines, we have the small intestines, and then clear down in the bottom there we have our bladder. And so, again, these organs can become fractured or punctured or ruptured. And if that happens with these organs, they tend to spill their contents into that abdominal cavity, which runs our patients at a very high risk for infection, gangrene, those types of issues. Now, those may not be seen right away. If we have let's say we have a perforated intestine or perforated bowel from, let's say, diverticulitis. And sometimes with diverticulitis, the bowels do perforate a little bit, or small pinholes. Sometimes they rupture into big tears. And now you get bowel content into that entire abdominal cavity, which doesn't take a rocket scientist to figure out that's going to cause some serious problems. Probably the seriousness is going to happen days or weeks later, not at the time that it's perforated. So we have to keep that in mind with our abdomen. So we divide our abdomen into 4 quadrants. Okay? Okay, and that's basically drawing a line down the center part of the abdomen, from the top part of the body to the lower part, so down that what we call medial line, and then one across the middle of the umbilicus or the belly button, from left to right. And that gives us 4 quadrants, and we very simply term those upper and lower left quadrant, upper and lower right quadrant. Now keep in mind, right and left is always the patient's right and left, not ours as the provider. And so that helps us to be able to, number one, document what we find on our patient, and number 2, helps us to kind of keep in mind what organs are in those quadrants, so that when we're assessing our patient and feeling, or they're telling us where the pain is, we can maybe associate that to an organ that lies in that part of the body. So you can see over here on this side, we've got our organs. We've kind of gone over those really quick, but you can see how those organs lie under there. Now the right or the top quadrants, the upper quadrants, some of those organs lie up in under the rib cage, which is significant if you're talking about someone that has sustained blunt force trauma or something that may have punctured or fractured a rib. We have those organs that sit under there. As you can see in the upper right quadrant is the liver. So if a rib gets fractured, and we haven't got to trauma yet, but keep this in mind, if a rib gets fractured, it can easily puncture that liver and could cause serious internal bleeding and potentially could bleed to death. Same thing over in the right quadrant, you've got your spleen that sits over there with exactly the same properties. So, and down in the lower quadrants, obviously the bulk of the organs are those intestines, which also can be easily punctured in a traumatic situation. So the peritoneum, we're going to talk a lot about the peritoneum. And peritoneum is a thin lining, and it lines the inside of the abdominal cavity. Let me back this up. There's a lining on the inside of the abdominal cavity, and then there's also a lining around each organ. Okay, so the peritoneum is the name of those linings. If we want to be specific, the parietal peritoneum is the one that lines the inside of the cavity. Okay, your visceral peritoneum is the lining around each organ, and both of those serve to lubricate and protect. Those organs are going to move around inside that cavity, and so those linings both have a fluid, or I don't know, I kind of think of it as small ball bearings on the outside of the lining. So when those linings move against one another, it doesn't cause friction and heat. The same thing happens in your chest. You've got your parietal peritoneum in your chest, which lines the inside of your chest cavity, and then you've got your visceral peritoneum, which lines, or we call it specifically a pleural lining, that lines the outside of your lungs. In between those two are small little, I think of them as ball bearings, but it's basically a solution or a fluid that makes those move smoothly against each other each time we take a breath. Otherwise, it would cause friction, like if you rub your hands together, it causes heat. And so if that's constantly rubbing against each other, it would cause heat and irritation and cause that to hurt. If ever we lose that fluid in there, then we do start to get that friction, and we call that pleurisy in our chest, when it hurts every time we take a breath. The same thing can happen with our abdomen. It's not as likely, but we still have those same properties inside the abdomen, which is going to be important in assessing pain. So most of the organs in our abdomen are enclosed within that parietal peritoneum. Okay? And I'll show you a picture in just a minute here. There are a few exceptions that lie in what we call the extraperitoneal space. So that's outside that peritoneal cavity. Those the kidneys and the pancreas, part of the aorta, obviously as it comes down in, lie in what we call the retroperitoneal. And you'll want to remember that term, retroperitoneal space. It actually lies behind the peritoneum, and that space can actually hold nearly your entire body's content in blood in there without really causing much notable distension in your abdomen. So if you've got a patient that's bleeding internally, it can, if it has the ability to get into that retroperitoneal area, a lot of blood can be stored in there, and you're not going to recognize it because it's kind of back behind everything. And then your bladder and the lower part of your intestines, and specifically the rectum, lie inferior to the peritoneum. So they lie actually below or towards the feet. So they're under that retroperitoneal area. And you can see all of that here. Here's your peritoneal area. You can see my little pointer. And in there lies most of our organs and goodies. Back here, you can see the retroperitoneal area comes up here. Right back here in our flank area on our back, you can see how this is very close to the spine, so it's very near the back part, and it doesn't sit, it sits to the side of the spine. You've got your kidneys, and this is why those helmet hits to the back in football are illegal, because if you would hit someone with a helmet with force right there, you could actually rupture their kidneys, which can be life-threatening. Most likely would be life-threatening. So your kidneys sit back there. The other things that sit back there is part of the aorta, okay, and a little bit of the vena cava sit back there. And then down underneath this area, you're going to have your rectum and then your bladder. So let's talk about some types of pain that you could have. Okay, visceral pain obviously is going to come from the visceral portions or the organs. So visceral pain specifically comes from organs within the abdomen. Those organs don't really have a lot of nerve endings, so the kind of pain that you're going to get from them is going to be pretty non-specific. You know that their abdomen hurts, their belly hurts, and oftentimes you hear these people describe this pain as dull or achy, but they can't really pinpoint exactly where it hurts. They'll tell you it hurts all over, or this whole side hurts. And the pain can be intense, but it's really not specific. And it's because there's just not a lot of nerve endings there to be able to pinpoint that pain. And so keep in mind, that's going to come from organs within the abdomen. You're going to get that visceral pain. Okay? A type of visceral pain is colic, and we hear this term a lot with babies. And colic comes from distension or contraction of the hollow organs, a lot of times very specific to the digestive tract. And that's why we hear this with babies, is their little bodies are trying to, especially they're newborns, trying to learn to digest their food. And so if the food doesn't agree with them just right, and this happens a lot more with formula-fed babies than with breastfed babies. But if their food just doesn't adjust to them right, their body has trouble digesting it, and so they do get this distension and contraction of the intestines trying to digest that, and we call that colic, and it's simply abdominal pain caused from the process of trying to digest and process that food. It kind of comes and goes, so you're going to have it. If you've ever had gas pains or had anybody that's had gas pains, that is colic. It comes, it goes, it gets sharp, it gets crampy, it goes away, and then it comes back. Persistent or consistent pain that doesn't go away generally comes from our solid organs. So that intermittent pain we're going to look at from hollow organs. Solid organs have a constant pain, and it really isn't going to get better and worse. It'll stay the same. So our parietal pain is another type of pain, and that comes from the parietal peritoneum, so from that lining. And there are a lot of nerve endings in that lining. So when we have a patient that tells us it hurts right here, and they can take their finger and show you where it hurts, really good chance that that pain is coming from that lining of the abdominal cavity. Most of the time they're going to tell you it's a sharp pain. Sharp, or sometimes they'll say stabbing. It's often severe. It's constant, and it's localized to one specific area. The last kind of pain that you may have is a tearing pain. So if you ever have a patient that tells you it felt like something was being ripped or torn, and this will happen just suddenly. It generally comes from the aorta. Now, this particular slide says it's the most common type of abdominal pain. In my experience, I have not found that to be true, so don't take that to heart. But it is a very severe type, and so if you have a patient tell you that they have a tearing pain, perk your ears up, start asking some questions, and listen very carefully to what they tell you. It's the separation of the layers of your aorta. So the aorta is actually tearing apart. Those layers are pulling apart, and you're going to get an aneurysm or a bulge in the aorta. And if you can picture this being like a weakening in an inner tube tire or a balloon wall, where it kind of bulges out a little bit, where it gets a little bit weak, that will happen in the aorta. But as we know, the aorta is a high pressure hose. So if we get a weakened spot in there, we also run the chance of that leaking or rupturing, in which case your patient probably will not fare well. So pay attention to that. In the retroperitoneal area, that aorta pain, if we get that aortic pain, the patients will tell you they feel a tearing or a ripping sensation in their back. And if you hear that, please don't think it's a back injury. Assume it's an aortic injury until it's proven otherwise. So with these patients, we want to be very, very gentle with them, because if that continues to tear or ruptures, if it ruptures, our patients have about 30 seconds before they bleed to death. So this is a pretty important one to remember. And then referred pain is going to be a type of pain. It's going to have qualities. It can be sharp, it can be stabbing, it can be kind of dull, but it is going to be a pain that is not located where the affected organ or area is. So a big culprit for this is gallbladder. And when our gallbladder becomes inflamed or irritated, it will oftentimes, and we know our gallbladder sits in the upper right quadrant of your abdomen, but frequently the pain, just because of the way the nerve pathways overlap, the pain for those people will oftentimes be up in the right shoulder or the very top part of the upper right chest. And even though that it's originating from the gallbladder or the abdomen, you're going to get the pain in the chest. So other things will do that, but the gallbladder is probably the most common one to refer pain. So if you've got referred pain, it makes it really difficult to pinpoint where the problem lies. So let's talk about some conditions really quick. These are some of the more common conditions that you're going to find. Appendicitis is a big one, and it's when our appendix are infected. Okay? Now, because it's infected and we have an infection going on, we oftentimes are going to see the signs associated with that. Low-grade fever, if it's been going on for a while, but specific to the appendix, nauseous, they're going to feel nauseous, okay? And they may be vomiting, and they may be vomiting a lot. So pay attention to that. Then their pain is going to be initially right around their belly button region. Okay? So when it starts, it'll be right around the belly button, and then it's going to kind of migrate down into that right lower quadrant, and we'll have a very severe pain right in there. And so that nausea, vomiting, low-grade fever, and then if that appendix ruptures, the pain is going to go away because the appendix now is no longer inflamed and pressure. It's ruptured, it's relieved the pressure, the pain is going to instantly go away. But as we talked before, that's when the real problems may start. If those contents get released into the abdomen, now we've got a case of severe peritonitis, and it makes it very difficult. There's so many organs in there to get in there and clean all that out and clean up the infection and make sure that we're good to go is very difficult to do. So if that happens, our patients become very sick very quickly. Peritonitis is an irritation of the peritoneum. It's usually caused, like we talked about, foreign material in that space. It's very sensitive, and when it gets irritated, it starts to contract the abdominal muscles. So what the pain comes from is not necessarily the irritation, but the abdominal muscles trying to protect that, and they start to contract up and cramp up. And so we get abdominal pain with peritonitis, and sometimes you'll have a rigid abdomen. We'll talk about assessing that abdomen in a minute. But a big sign with peritonitis is if you press on the abdomen and let up very quickly, the pain is going to not be there. I mean, pressing on the abdomen is going to relieve that pain. That sudden release is going to be extremely painful. So when you push down and then let go, if they cry out in pain, or they reach over and immediately put the pressure back on their abdomen, start thinking peritonitis. So cholecystitis, or gallstones as we normally call them, is an inflammation in the bladder. And your gallstones are actually a accumulation of little minerals and things that your body has collected in the gallbladder. And if those stones get stuck in one of the ducts of the bladder, the gallbladder, it can cause a great amount of pain. Now, your gallbladder typically produces bile, which goes into your digestive system to help us break down our food and be able to extract the nutrients from that. So when a stone gets stuck in there, then the body can't produce bile. Oftentimes this is going to make you feel nauseous. Gallbladder incidents, gallstones, can be triggered a lot by fatty foods. So if you eat foods that are fatty, such as peanut butter or a steak or salad dressing, you're going to find that your gallbladder will kick in and become much more painful. And again, we talk about that pain can be referred pain with your gallbladder. So my daughter had hers out. We see this happen a lot after a woman has a child. And I don't know what it is about childbirth that triggers this, but frequently women after their first or second child will have their gallbladder removed because of gallstones. My daughter had hers removed a couple years ago after her first baby, and the doctor said she had, he said not a stone, but literally hundreds of stones, and he actually showed us a picture later. It was amazing how many stones, but she had stones big enough they were actually stuck in the duct. Now, if it's just one stone, they can go in and just kind of laser that apart, break it apart, and let it work itself through. If there's a lot of stones in there, they frequently will remove the gallbladder. And that then will cause problems with them digesting. They have to kind of learn to adjust their diet accordingly because they're going to be missing that bile production. Okay. So severe upper right quadrant or epigastric, that top of the stomach type pain, and oftentimes this is referred to the right shoulder. Okay. So a good thing to say, ask your patient about this is if they've ever had a history of gallstones. If they have, much more likely that they're having another episode. Pancreatitis is the inflammation of the pancreas, and this is not all that uncommon. It's very frequent in patients that are chronic alcoholics or have a history of alcohol abuse. It presents with upper gastric pain, and oftentimes this pain is referred clear through to the back or the shoulders. So oftentimes the patients will tell you they have back pain with this. and it's an inflammation of the pancreas. Now, are we going to know that pre-hospital? Probably not, but we can make a good guess. GI bleeds are kind of an interesting duct. It is bleeding within the GI tract, and so in this tract, it can be bleeding in the stomach or above, or it can be bleeding below the stomach. Okay. The blood is eventually, either way, going to exit the body, and that's when we're going to be able to recognize it. So if it's bleeding in your esophagus or in your stomach, then you're going to vomit that up. The stomach really does not like to have blood in it, and blood in your stomach almost always causes you to vomit. When you vomit that, it's going to look like, we call it coffee ground emesis. It's going to look like they're vomiting coffee grounds, and it's not. It's just that coagulated old blood after it's mixed with the stomach acid, and it will look like coffee grounds. So ask your patient if they're throwing up what it looks like. Or if you can look at it, go look at it and see if it looks like it's got that old blood in it. If it is in your intestines or below your stomach, then we're going to see that come out in the stools. And oftentimes those come out looking like, we call them black tarry stools. If you've ever had a newborn baby and that black tarry first bowel movement, it looks very similar to that. It's kind of thick, kind of slimy and black, and that's blood in the stool. So we want to ask those kind of difficult questions to ask. I know I always felt a little weird asking people about their bathroom habits, but it is important in this area, and if they're sick, they really don't mind telling you. Also, when you have a GI bleed, it has a certain smell about it, and I can't describe it to you, but once you have smelled a GI bleed, the next time you go into a home and somebody is bleeding in their GI tract, you're going to recognize it. And so, as my instructor always told me, if it looks like a duck and walks like a duck, it's probably a duck. So recognize or think about that smell when you first go in and associate that with your patient care, and it will help you make better clinical decisions down the road. Generally, these oftentimes are not painless. A bleeding ulcer really doesn't hurt that much. Bleeding in your intestines does not hurt. It causes other problems to make you sick, but it's not painful. Gastric ulcers can be painful, and if the ulcers in your stomach go all the way through your stomach wall, then your stomach contents can leak out. So, and that can be true in severe cases in your intestines too. If you get ulcers, irritated spots that are continue to be irritated, and they will actually just kind of work through and right through that wall. So if you're getting that rebound tenderness, we call it, where you're pushing in and it releases suddenly and it hurts, and you've got evidence that you've had a GI bleed somewhere, you may be looking at a perforated ulcer. Signs and symptoms we talked about, going to be that black tarry stools. If we get, they're calling it frank blood, but if you get red blood, that bright red blood from the rectum, that's more of hemorrhoidal bleeding. It's not bleeding in the GI tract. It's probably just bleeding from the rectum area where it's maybe torn, especially if a patient has been constipated and has had a larger bowel movement than normal. It may tear that rectal tissue just a little bit. Generally, those aren't anything to worry about. The coffee ground emesis we talked about, being blood in the stomach. And if they're vomiting that frank blood or that bright red blood, then we're looking at probably a tear in the esophagus. And that can be really interesting, and it can be very messy because our airway is compromised when we start vomiting blood. And we're going to vomit this up, and it's oftentimes caused from what we call esophageal varices. And basically that's like varicose veins in your esophagus. So these veins have become a little bit engorged and run the risk of rupturing. If they do rupture, it really is pretty dangerous. They're going to be vomiting. We want to keep those patients sitting up, leaning forward, and protect their airway at all costs, knowing that they're bleeding. So if it's an artery that ruptures, we're in really serious trouble. If it's a vein, they still can lose a significant amount of blood. So these patients will be transported very quickly. We talked about that tearing pain being a aneurysm in the aortic artery. So we call that a AAA, is what it's called most frequently, but it's the abdominal aortic aneurysm. So that's that ballooning and weakening of the aorta wall, and it can continue to grow. They're going to measure it. If it's a small one, they may let it go for a little while, and they have specific ranges where if they're above this this length or this much bulging, that they will go in for surgery. I've had a lot of patients that have had these. A few have survived, but for the most part, when you get at the point that they're tearing, if we can't get them into surgery to get that fixed pretty quickly, and it does rupture, they may not survive. These patients may not be the best candidate for a helicopter, because that atmospheric pressure change can have an effect, and it actually, when they go up, the atmospheric pressure is less. So in the balance, it makes more pressure in the inside the organs or inside the aorta, and because we lessen the pressure on the outside, we run a greater risk of that rupturing. So if you've got this kind of patient and you're out at a distance enough that you might consider flying a patient, think twice about this one. But we do need to handle them with absolute kid gloves. So they don't do any walking, they don't do anything strenuous. We're going to place them very gently on the cot. We're going to drive very gently, because any contracting, if they're working to hang on or anything, can cause that to be worse. So signs and symptoms, we talked a little bit about this. Sharp tearing pain or ripping pain. Oftentimes I tell you it's in the back area. Sometimes when you're palpating the abdomen, you can feel a pulse in there. That's not normal. So if you feel a pulse, you are feeling that bulge of the aneurysm. So if you feel it, stop. And don't feel it again. Don't palpate anymore, because the last thing we need is you pushing around on that weakened spot and making it worse. So just know that a palpating mass in the abdomen, and you're going to hear that term a lot, we're going to hear it more than we actually feel it. But if that happens, you know exactly what it is. Okay? Other things you can check are your pedal pulses. I know pedal pulses are hard to find, but if you can check them and compare them, oftentimes with a AAA, you're going to have pedal pulses that are stronger in one foot than the other. So that if you're thinking maybe it's a AAA and you find that, that's kind of a confirmation that you are indeed dealing with this. So if we have a sudden or very severe increase in our pain as we're taking care of our patient or before we get there, that may mean that it has ruptured. So they're going to bleed. They'll very quickly progress through the stages of shock, and this very oftentimes, most of the time, is a fatal hemorrhage. Hernias are a hole in the abdominal wall. So that abdominal wall has gotten a hole in it, and some of the tissues, oftentimes it's the intestines, protrude through that parietal lining and protrude out against the abdominal skin. So when we're lifting, we're using abdominal muscles that's putting a lot of pressure on those abdomen organs. And so when you're lifting heavy things, it may actually squeeze those organs outside through that hole to the outside. So instead of being under the abdominal lining, part of those intestines are sitting between the abdominal lining and the abdominal skin. That, if it's temporary and they kind of move in and out, probably are not that big a deal. If they get caught in there and they become strangulated, that can become a very serious issue, because we can actually kill off part of our bowel and become septic because of this dead tissue, which can be fatal if it's not caught. So if there's a risk of that happening, frequently patients will go in and they'll actually do surgery and go in and suture up that hole so those abdominal organs will stay inside that parietal lining where they belong. So this is something you can visually see, feel. Patients know that they have it oftentimes, and you see this a lot more in men than you do women. Okay, so sudden onset of abdominal pain, usually, like we say, followed from heavy lifting or exertion. And you'll probably feel that mass or a wall. And sometimes you'll see these herniations kind of down in the groin area too, down way lower in the abdomen. Renal colic is a really fancy term for the pain that's caused by a kidney stone. And this is a stone, oftentimes it's calcium that's built up in the patient's kidneys, and that stone, much like our gallstones, gets caught in the ureter, that tube that takes urine from the kidney to the bladder, and you'll get a stone caught in there. People that have had kidney stones will say it's one of the worst pains that you can have, comparable to childbirth. So men get these very frequently, probably much more than women do, but that's notorious for their cramping, severe cramp, and it's back in that flank area where the kidneys are located. Sometimes you will have pain that goes down into their groin area. Frequently this is accompanied by nausea and vomiting. And these patients are going to be hurting, really, really hurting. So if they've got that back pain and decreased urine output, possibly, if they just really aren't able to pee like they normally are, or decreased urine, they're not peeing much. It doesn't necessarily hurt when they pee, it hurts all the time. But because that one kidney is blocked, they're not going to have as much urine output as they did before. So this is going to be much more of an emergency for them because they're hurting so bad than it is an actual emergency. And like I say, frequently they'll pass those stones. Sometimes they go in and do an ablation or a little laser and break those stones up if they're too big to pass. But pain control is going to be your big thing here. So if you think that's what you've got and somebody's in a lot of pain like this, ALS would be a good option so that we can get that pain under control for them. So always think about cardiac involvement. We talked about referred pain, and referred pain being pain that is someplace different than the actual injury or origin of the pain. So because of that, because our chest and our cardiac system lies so closely in with our abdominal system, we always have to think, if we've got epigastric pain, if we've got indigestion or a digestive discomfort, we have to ask ourselves, could this be cardiac? In my case, I've been a paramedic 20 years. My rule of thumb has been, if they have pain above their belly button anywhere, I'm going to consider it cardiac until I can prove otherwise. Specifically, when you're talking about women of any age, when you're talking about anybody with diabetes, or when you're talking about an elderly person over the age of like 65, those three groups of people do not present with typical pain. So always think about a cardiac issue being involved. And you're not really going to know that until you get ALS there to do some further diagnostic testing. So you're never going to be wrong for calling ALS on an abdominal emergency when you don't know what it is. Okay, let's talk about our assessment really quick. Many causes. Okay? Because it's such a a non-specific area and we cannot really assess it very well, we're not going to diagnose this. Okay? It is perfectly fine for you to say abdominal pain and leave it at that, because we really don't know what it is. If you get a little more information from your assessment, feel free to put that in there. But frequently when we put a diagnosis on something, we're trying to kind of like telling the doctor what's going on, and we really don't know. So we want to stay clear of that. And the diagnosis of abdominal pain is perfectly fine. But we want to do a great, obviously, primary assessment, but our secondary assessment is going to tell us a lot about these patients and hopefully help us to identify the life-threatening conditions that we might find. Okay, so scene size up, you all know how to do this. Okay, look for odors. We talked about GI bleeds having a specific odor. You will know it when you smell it, I promise you. Protect ourselves from bloodborne pathogens if they're bleeding, if they have infection, if it's a viral thing, we want to know that. And then try to figure out, is this a medical patient or a trauma patient? Because trauma plays into abdominal emergencies a lot, even if it's trauma that happened a day or two previous. So get our ABCs taken care of. Number one, we got to make sure we have ABCs, especially if they're vomiting. We have to protect that airway. So we are not going to lay those patients down. They're going to be up where they can get the vomit out and not impair their airway. If they suck down stomach contents into their lungs, really high chance that even if they survive whatever's wrong, they're going to succumb to aspiration pneumonia, because that stomach acid in the lungs is very detrimental. So protect the airway. Okay. Think about oxygen. If your patient appears to be hypoxic, so if their skin color tells you they're hypoxic, if your pulse oximetry indicates they're hypoxic, if they're working to breathe, or they have an altered mental status, we want to give them some oxygen. Okay? If none of that applies, then they're okay to go without, but we do want to make that consideration. Then we're going to ask them our OPQRST questions, and this mnemonic of questions, this set of questions, is going to be enormously helpful to you and the care providers you take it off to. So we want to know, when did it begin and what were you doing when it started? Okay. And then those P questions, what makes it better or worse? So provocation means what makes it better. Palliation is what makes it worse. Okay. Does it hurt more when you move? Is there a specific position that's better? Oftentimes you're going to find patients with abdominal pain are more comfortable in the fetal position, because when they pull their knees up, it relieves the pressure in the abdomen. They've got more room in their abdomen because those muscles on the abdomen aren't stretched tight. So transport these patients in a position that, even if you want to protect their airway, stick a pillow under their legs so that they're bent at the pelvis, and you're providing that relief of the pressure in their abdomen. Okay? So look at how they're sitting, look at how they're laying. And then we're going to ask them to describe. Please don't put words in their mouth. Don't say, what would you say? Is it dull or sharp? Because then they're going to choose one of those two, and what if it's tearing? You would miss it. If you're only giving them the option of dull or sharp, and they say, well, I guess it's sharp. But if you told them, describe to me this pain, and they said, well, it felt like something like tore, that's an entirely different scenario, and you want to know that. So just ask them to give you words. Don't put words in their head. See if they can point to the location. So in that region or radiation, where is it, and does it go anyplace else? And then on a scale of, I struggle with this. I always use a scale of 0 to 10, because to me 1 to 10 is inferring that they have pain. One being a little bit of pain. I want to give them the option to tell me that there is no pain. So I always use the scale of 0 to 10. 0 being no pain, 10 being the most extreme pain you can imagine. How bad is this? This is always a little bit of an interesting question, because some people really have not ever experienced a great amount of pain. So they really have a hard time. I mean, their 10 might be like your 5, depending on both of your life experiences. But it really doesn't matter, because we're always going to go by their scale. So it works out either way. Okay. And then we want to know, time, do you have this pain all the time? Does it come and go? Is it intermittent? Is it constant? Tell me about this pain. Okay. Now, if you have women, because we also have the reproductive cycle in here, there's some questions we want to ask our female patients. So, where are you in your menstrual cycle? So when was your last period? Are you on your period? However you can ask that question. It's uncomfortable, especially from a man's point of view, asking a woman, but it is important. Okay. Is your period late? Because there's a chance this could be an ectopic pregnancy or a tubal pregnancy where the fertilized egg let me back this up. The egg has gotten fertilized in the fallopian tubes and attached itself to the wall of the fallopian tubes. Causes a great amount of very sharp abdominal pain. And if it ruptures, we run that same risk of having peritonitis set in. So this is important for us to know with women, especially if they're in those reproductive years. So is your period late? Oftentimes when this happens, the women don't even know yet that they are pregnant. So we want to start asking this question early. Have you been bleeding from your vagina? Something that isn't menstrual bleeding. And if you are menstruating, is it normal? Is the period a normal flow? Is this normal for you? Or is there something abnormal about this? Okay. So all of our patients, we want to ask, have you had this pain before? But specifically, with our female patients, we want to ask, again, is there a possibility that you're pregnant? If they tell me no, I always verify with no meaning you're not sexually active, no meaning that you're on birth control. What does no mean? If you're talking to a younger female and her parents happen to be around, find a reason for mom and dad to leave and then have this conversation with her. She probably is not going to be very excited about talking about her sexual life in front of mom and dad if she's 14 years old. So, maybe something you have to get down to her level, look her eye in the eye and tell her, I really need you to be honest with me. This is between you and me, but I need to know if you're sexually active. And, when they're sick and hurting, they'll be honest with you most of the time. So is there a possibility you're pregnant? Are you using birth control? And if so, what are you using? And get those questions out there. Then we're going to go into our sample history. We should already have our signs and symptoms because we've asked them to describe the pain to us, all of that. So now we just need to go into allergies, medications, blah, blah, blah. If you have not asked about birth control at this point, this is the opportunity to do that. Most women don't consider birth control a medication. So when you ask them, do you take any medications? They're going down through anything I would take because I'm sick. Birth control pills aren't taken because they're sick. Neither are the depot shots. But it would be important to know that in this case. So make sure that you specifically ask about those. Pertinent past history. I find a lot of students ask, has this ever happened before? And that's their question for pertinent past history. That's not inclusive enough. I want to know about them as a whole. So I ask 3 questions. Have you seen a doctor for anything? Have you had any surgeries? And if you've been to the doctor have you been to the doctor in the last year? If so, what'd you go for? And that's going to give me a little better idea, along with their medications, about what their history is. Then last oral intake. This one becomes very important when we're talking abdominal pain because of the gallbladder issue. So if they've had a meal that included some fatty foods or foods with oil or a high fat content, and that can be yogurt, cheeses, all of those things, and that pain got worse after they ate, that's a trigger for gallbladder. We want to start thinking about that. And then E, the events leading up to this. So our geriatric note is our older people start to lose their ability to perceive pain because their nerves start to wear out. And Diabetics are exactly the same. Diabetics lose their ability for the nerves to operate like they should. So those class of people are not going to be able to perceive pain the same as someone that's younger and healthier. So we want to consider that they may have a more serious cause to abdominal pain simply because they're older. They're more at risk for things not working correctly, and also they can't feel when it hurts as much. So they have more higher risk. That's good English, isn't it? More higher risk for life-threatening injuries. Other things that can happen, medications, specifically your, what do I want to say, like Pepcid, Pepcid AC, Prevacid, Prilosec, those things that are taken to control gastric functions, so to control heartburn and things like that, run a higher risk of GI bleeds when people are taking that. So medications can cause a lot of, all medications have side effects. So older people tend to take more meds, so they run a higher risk in addition to their physical aging processes. So what we're going to do is we're going to inspect and palpate our abdomen. Okay, so inspect, we're going to look at it. We're going to look to see if it's distended, if it's pooching out. Now, we probably aren't going to know what these patients look like normally, so ask them, ask a bystander or a family member, friend that's there, is your abdomen more distended than usual? Okay? We're going to look for discoloration. If they have bleeding in their abdomen, there's a chance that we may see it be a dark, kind of a bruised color from that blood that's in the abdomen. And then we're looking for protrusions, things that are a little out of place. Specifically, the hernia would be a very specific protrusion that we would see. But if we've got an infection in one place or bleeding in one part of the abdomen, we may see it protruding out or definitely being distended or rigid, more hard than other parts of the abdomen. Okay. So to palpate this, if they tell us where the pain is, we're going to palpate the other quadrants first. So to do that, I wish I could show you, but I put my whole hand, I start at the heel of my hand and put it on the edge of the quadrant, and then I just rock my hand down until I've got my palm, my fingers. So I actually palpate that entire quadrant with the full part of my hand. So I'm not just poking with my fingers, feeling little areas. I want to feel that entire quadrant. I'm feeling for rigidity. I'm feeling for distension. I'm looking at my patient's face to see if they grimace, because if that hurts, you're going to see it in their face. So I'm watching their face as I do that, and I'm also feeling for any pulsating mass that I might feel in there. Okay? So obviously, if an area hurts, we don't want to do a whole lot of poking around in there. We know it hurts. But what I do is I like to put a little pressure on it and then let go to see if that increases the pain. Okay. So again, we're looking for rigidity. We're looking to see if we can recreate that pain, and we're looking for guarding. And guarding is that they're protecting that area. Frequently, they do that without really realizing that they're doing it. So if you go to touch an area and they reach up and lift a leg to protect it, or put their hand over an area so you can't actually palpate there, that's a sign that there's pain and tenderness there. So our vital signs with abdominal pain, we're going to assume the worst. And so we're going to do our baseline vitals, and then we're going to reassess every 5 minutes. And that's going to be all of those vitals that we take: pulse, respiration, blood pressure is going to be pertinent. If they're bleeding, we want to know that. Pulse is going to be important, because if they're bleeding, they're losing blood, their pulse rate's going to go up, trying to compensate and move the little blood that they have left around faster to give oxygen to the cells. Look at their skin color, temperature. If they become more pale, that's a big sign. If their mental status decreases, that's a huge sign. So we're going to watch all of these things every 5 minutes and try and trend that as closely as we can. Okay. So some of our abdominal distress is going to come from our digestive system. As we talked about, we could have diabetic issues, we could have cardiac issues, we could have food poisoning, we could have the flu. Lots of things that can play into this. We could have other types of poisoning that would play into this as well. So again, we talked about this earlier, but pay attention to their airway if they're vomiting or they tell you they're nauseous. Be ready for that and don't get caught unaware. If they tell you that they're nauseous, put them in a position where if they vomit, it's not going to put their airway at risk. So either sitting up or laying on their side, so when they vomit, they can get that out. Okay. We're gonna calm our patient. We're gonna try and reduce their anxiety because that's only going to benefit them. And these patients, whether they're hungry, thirsty, whatever, we don't give them anything by mouth. So no Tums, no anything like that. If we need to think about pain control or heartburn issues or anything like that, call ALS or get them quickly to the ER and let them take care of that. So maintain our airway, have suction ready, position your patient correctly, left lateral recumbent position. If they prefer to lay, a lot of times, like I say, these people will prefer the fetal position. So lay them on their left side. It takes the pressure off their vena cava. We want to keep oxygen sats at 94 or above, and then transport them to the appropriate facility. So that is abdominal in a nutshell. I hope you learned a little bit. Please read your textbook.